Hello, everyone. Thank you for joining the frameworks today. We appreciate you taking the time. We think we have great content today from our universities. We're excited to hear about the challenges they faced and the plans they have for the spring. We're going to begin here with Patty Martin, our president and CEO of BioCrossroads. Patty, will you open us up for the webinar?
Happy to. Thank you so much, JoBeth. Welcome everyone and Happy New Year. I know that we had an unsettling day yesterday across the country, and we appreciate everyone refocusing efforts and coming back to join us today for our second vaccines frameworks. Just to provide a little bit of history here, we decided a while ago that it would be really helpful to inform people and educate our communities about the facts behind vaccines. Our history for the state of Indiana was shared in a frameworks back in November on the 19th, which you can find on our website. Today, we have lessons learned from our university partners. We're very excited to have them join us. And then later in February, we will have an additional session that gets into the facts and differences of the different kinds of vaccines so that we're all informed and educated as vaccines get rolled out across the state and across the country. So please join us later on in January. Today, I want to welcome our university partners, and I'm very excited. We've come to know this group of esteemed individuals over the last almost year. We started having conversations back in June of last year. We have met over 25 times. And it has been a very informative, very energetic, and very compassionate group, quite frankly. As you think about what the universities have gone through to exercise all kinds of energy and safety to ensure that students and faculty and staff and the communities surrounding our universities are safe. The stories here are really telling and really informative. I was reflecting earlier today on just the size of the populations that our university partners have to deal with. I'm from a small town. I'm from Wabash, Indiana, which when I asked Siri today what the population was, it's about 10,000. And honestly, that's fewer people than Notre Dame, which is the smallest university represented on our panel today. When you think about the size of Fort Wayne and Evansville together, you get close to over 250,000 people. And honestly, that's about the number of folks that we've been operating with. And remember, it's not just students and faculty, it is everyone that supports these communities and everyone in the communities surrounding them. So we really wanted to give a hats off to our university partners for everything that they've learned. We first engaged with this group when we were trying to find PCR testing capacity across the state, and that quickly evolved into conversations about how the universities could stand up their own testing and ensure the safety of their faculty and staff in a manner that would not drain the resources of the state in general. And I think I, for one, am a very proud Hoosier that our universities stepped up in the way that they did to secure the safety of their communities without putting the safety of the broader population of the state at risk or in second position. So I want to go ahead and turn to today and say that I hope that you'll listen to these lessons. Interestingly enough, when we planned this event, we thought we'd be in a different position. We thought we would be in a situation where where we would have the vaccine rolling out more quickly than it has, and that perhaps all universities would be going back into in-person teaching. We didn't expect to be at the place we are today. So while these are lessons learned, they are certainly lessons to be applied. We're not out of the woods. And so I hope that you'll take to heart what these folks have to share with you today. And we'll be going ahead and taking questions in the chat feature. I'm sorry, not in the chat feature. If you raise your hand, we will call on you to get your question. And then if you want to put it in the chat feature, please go ahead and do so. We're going to try to do our best at making sure that your questions get answered, because that's the whole intent of this frameworks, is to inform and educate and hopefully raise the bar for everyone across the state. So I want to go ahead and introduce our first guest. Dr. Erin Carroll is the Associate Dean for Research mentoring at Indiana University. And we're very excited to have Erin here. He's the newest addition to our group. We've had a number of folks from Indiana University involved with us. And Erin, I'd like to go ahead and hand it over to you and welcome your comments. Thank you.
Thank you. Thank you so much for having me. We can start with the slides. So we can actually go to the next slide. So back when the pandemic really hit and everybody started to get nervous, and especially when we started shutting everything down in March, IU responded by setting up what we call the Restart Committee, which was a large group, not too large, but a reasonably large group of experts across our various schools in medical and public health, and a few other areas to talk about what we might need to do to make campus safer, and what we might need to do to be able to restart not just campus, but even some of our activities like research. And we eventually landed in a response that had at the time 3 pillars, and we've recently added a 4th. But those 3 pillars, and none of this is anything we invented, this is to some extent the epidemiologic playbook, but first we needed to know that we could do symptomatic care and testing, that anyone of our constituents, and if you add up students, faculty, and staff, we're at something like 120,000 constituents across all our various campuses, that anyone who was symptomatic, who was concerned that they might be sick, could access healthcare, who could get a telemedicine visit with a healthcare provider, could talk about symptoms, and if needed, be quickly referred for symptomatic testing, which at the time was a nasopharyngeal swab for PCR test, could then quickly get an answer and could figure out if they needed further care, and could also actually get care if they needed, if they needed hospitalization, if they needed a doctor visit, whatever else it might be. And for this, we mostly partnered with IU Health, who's clearly a partner of ours. We set up that pillar. The second pillar was, what do we do if people turn out to be sick? We need to be able to not only respond to them and get them the healthcare they need, but to do isolation and to do contact tracing. And we quickly realized that while the state was rapidly trying to build this kind of infrastructure, that it was not going to be adequate for what we would not need to do, not only just for the extended campuses, but especially for congregate living or for classrooms or for anything else that might be occurring. And so we built up a significant infrastructure of our own contact tracers. I think we might now have 40 employed just within our own IU system. Being able to answer the phones, answer questions, to do contact tracing, to figure out who might have been a close contact, to get those people into quarantine. And then specifically for our congregate living students to actually have separated quarantine and isolation space, to adequately know that we had enough dorms available, which were specifically set up for quarantine or isolation, that if we needed to move students to get them out, that we could house this. This was a huge lift, getting all of this done, and it's worked out incredibly well. Our teams have worked in concert with all of the local counties and boards of public health to make sure that we're not stepping on their toes, to know that we're doing contact tracing within our own units, but also to be able to relay information when contact tracing needs to occur outside within the IU confines. And it's worked incredibly well. I think our median time to close a case is now under an hour. So every time we have a positive or we have a new person who's been identified as a close contact, it takes us a median of less than 1 hour to talk to them, figure out if they have any other close contacts, what needs to get done, and then to work on that. And it took us some time to get there. I mean, the first few weeks of campus were chaotic, especially as we had the surge that I think most campuses saw after students returned to campus, as we were still trying to build infrastructure. This was still a work in progress. But as we've increased our workforce and as we've gotten better at this, we've become actually rather efficient, and it's working out quite well, especially as the state has become more and more constrained and been able to do less and less contact tracing of their own. The third pillar, which is really what I have worked on, and I'm director of our asymptomatic testing and mitigation, is all of the asymptomatic testing that we knew we would need to do based upon lots of models to keep it safe. So over the summer, there were a lot of key studies that came out, a really good one out of Cornell, and a couple others, one published, I think, in one of the JAMA journals, that talked about the fact that to truly be able to make an argument that we are making being part of the community safer than not being part of the community, you needed a significant level of asymptomatic testing. And that's always been our goal, and a mantra that I've said over and over again, that especially in light of a state where community transmission is occurring, our goal is not zero. I mean, I'd love to get transmissions down to zero, but it's unrealistic that if you live in a community where community transmission is taking place, that we should react to the fact that any infection is occurring as a failure. Our goal is to make it safer to be part of the IU community than not to be part of the IU community. One of the ways we do that is by monitoring what is going on in our communities and then reacting locally. So the first thing that we do is make sure that we are testing a significant proportion of all of our groups of faculty, students, and staff wherever they are on all our various campuses. So that is a random sample testing that we do of faculty, students, and staff in each of our large constituencies and groups on all of our campuses. But we also do a fairly large amount of what we call mitigation testing, which is testing where we're actually trying to find as many infections as possible and then getting those people into quarantine and isolation. So trying to find all the cases, recognizing that, again, perfection is not achievable. What we quickly realized was that most good studies also showed that what mattered more for doing this type of testing was not the test characteristics, not the sensitivity and specificity, as much as how quickly can you do tests, how quickly can you get the results back, how many people can you test, its volume. More is better than perfect. And so we also devised schemes by which we wanted to start with as few infections as possible, keep them as low as possible, and then move in. So first thing we did was we thought about doing pre-arrival testing, and we wound up trying to get as many people as possible to do tests before they arrive, but that's hard to do given with people still traveling and everything else. So we focus really on arrival testing. We set up antigen testing for every student moving into congregate living. It was a huge undertaking. If you had seen the stadium parking lot in Bloomington, that 12-day period, there was an army of people working it, and it was very efficient. We got, as every student arrived, usually with parents, we were able to take a sample, move them into a parking lot, get them a result, and decide if they're positive or negative, usually within 20, in fact, almost always within 20 to 30 minutes. And so if they were negative, move on in. If you're positive, you can move into isolation housing or go home and then isolate there and then come back. But we did this for all arriving students. We also did PCR testing for all off-campus students in Bloomington. We did something like 40 to 50,000, I felt like, arrival tests. And then we shifted rapidly into the mitigation testing. For that, originally, we relied on an outside vendor. It was Vault Testing, who do a saliva-based PCR. But we also started building up our own testing capacity, and that came online slowly in October, but is now up to full capacity. We have 3 labs, one of them in Bloomington, 2 others in Indianapolis. All of them have 2 functioning robots, and our capacity has grown quite a bit to now where we're doing about 25,000 tests a week just between Bloomington and Indianapolis alone, and ramping that up for about 50,000 tests a week in February as students come back to campus, because we really want to be able to avoid that surge that we saw at the beginning. Those are all saliva-based PCRs. We say out loud that our goal is to get tests back next day, but often results are back, and these again are PCR tests same day. So I'll get tested on Friday, and it's very possible I'll get my results back on Friday. So it works incredibly well. And then our newest pillar is vaccination. So we have a new sort of addition to the MRT, a 4th lead who is coordinating our vaccination response of, initially more faculty and staff, but also preparing to do students when we need them. Next slide. Of course, we have some extra resources that we put to research, and we in fact even had a second restart committee for research. We set up a bench and clinical restart checklists and templates. We, had specific plans. We built websites. A lot of this is communication and a dedicated email account for all kinds of questions. We do specific research webinars. These are focused on our research teams, because we recognized quickly that research was essential, that even as everything else shut down, this was the first thing that we opened back up. Even before many of our campuses, we had to make a real push for research. We wanted to make sure that we dedicated specific personnel and tasks to get that going. But all of it at this point has been pretty much folded up into one large program. Next slide. And so again, in the fall, we tested over 240,000. And this is just asymptomatic testing, students, faculty, and staff. That's on top of the symptomatic. There was really no evidence. And we even did a quick and dirty study to look at this where we checked about how many class hours students were registered for in person and whether there was any correlation. And we do real due diligence with every case to see if there was evidence of spread, and we could detect none really in classrooms and labs. Of course, we are de-densified, spread out, universal masking, great cleaning, great ventilation. So doing everything right, but it's turned out quite well, and we're trying to push for as much in-person education as possible next semester. The 3 labs are now capable, as I said, we're capable of doing more, but we're staffed up to doing 50,000 tests a week. We're also now starting to shift our symptomatic testing into these labs as well. It's just easier to do everything under one house, and getting ready for the spring. I put a chart up there just showing how things went in the fall. What you're looking at there is asymptomatic testing only. And clearly the y-axis is different, but you can see that we bumped up to about 6% positivity, which is not prevalence, I should still say, because we were truly focused on the dorms and the Greek houses, and the vast majority of our positives were even in that period were Greek houses, and it was all over the news, and I'm sure you probably saw it. But once we got a handle on that, which really happened about September-ish, we pushed our positivity levels and our prevalences down into the 1% level, which were they remain for the rest of the semester. And even as Indiana heated up in October, November, December, we kept things a pretty tight lid on it. And so our positivity and our prevalences have really never bumped above 1%. And as I said before, we're going to massively push testing in January, February to try to avoid that in the surge. And I think that's about my time. Oh, no, I still do have, I think I have a few minutes. I don't know if you wanted to do questions. I saw some, happy to take some.
Erin, I think there's a question from Patty Martin.
Sure.
How and where was PCR testing capacity added to support same-day testing for IU?
And also,
So
I'm curious about the supplies and just, again, from lessons learned, how did you come to that? And would you do it differently, next time?
So we benefited. I mean, a lot of this is, it's a tired cliche at this point, but it's all building the plane while you're flying it. So we had so many moving parts, but as we were, getting the labs, we started ordering equipment, which mostly involved PCR machines and the robots, because we knew we were going to need to do high throughput. And we were also started investigating the various EUAs that were out there in order to do saliva-based PCR. And we landed on saliva-based because you need, again, throughput. Nasopharyngeal swabs are slow and they require PPE and they require a one-on-one interaction. Saliva, I mean, if you someday get a chance to come down and see one of our sites, it's amazing. I mean, people are just constantly being shunted along a pathway where they're just drooling into a tiny vial, they seal it up and off they go. And at the time, University of Illinois published their own EUA of a new process that they developed, which was different than the typical Rutgers EUA that a lot of places use for saliva-based PCR, that is faster, cheaper, pretty much the same kind of quality, but requires far fewer reagents and supplies. So all you do is basically heat up the vials and you just collect saliva, nothing else. Heat it up to kill it for like 30 minutes and then run the PCR. You get the same kind of result. So because of this, and with the robots, we're able to process, we do it in runs of about 376, and we can get through many runs per robot, per day, per lab. If we were willing to run 24/7, we could do an ungodly number of samples. But at this point, we're setting up for 2 slightly overlapping shifts per lab per day to get to 50,000. And that just the throughput allows us to get results back sometimes same day, but always next day. And also, the new EUA allowed us to avoid many of the bottlenecks in terms of supply and reagents that others. Our biggest issues have been pipettes, or tips, for the robots, but we're getting through that, and vials initially. But we now have more than enough vials to go, because we have a lot of variability because we aren't really constrained by size as much. It's more just having to not reprogram the robots.
And,
so I see somebody asking her, go ahead.
Yep, I was going to say, if you can see the questions, Dr. Carroll, we'll just let you get through the next one, and then we'll save the third question for the panel and go to the next guest. But if you could answer the next question.
So did IU allow time for their employees to recover that did not impact or take from their personal time off for the calendar year? It is, I mean, granted, yes, that is an HR issue. I do think so. I mean, especially with quarantine and isolation, you don't want to penalize people for doing the right thing for quarantining. So I mean, in the groups that I've worked with, we've been quite lenient in making sure that people, that we were endorsing proper quarantine, isolation, and taking care of yourself while you were sick, because otherwise you're fighting yourself. If you're telling people that they have to take vacation time or time off to stay in quarantine, they're not going to stay in quarantine. And our goal the whole way was to be as safe as possible. So we tried as hard as possible to make it, so that there were no penalties to following our guidelines.
And we actually do have a quick question from Vivian. If you want to
Sure.
answer her 2 questions, you do have.
So I see there too is the platform that we utilize for PCR testing with the high throughput. So again, it's an incredibly simple EUA that again, I got to give all credit to the University of Illinois for doing. But basically, we heat and activate them in a bath, which is basically killing the virus for a period of time, and then we go straight to running a PCR. We look for 3 different positives or, against controls. So 2 of the 3, usually we get 3 of 3 positives for positive, but it has to have 2 of 3 positives to be a positive. If it only has 1, we will recheck it, sometimes even multiple times. And if we still can't clarify, we call it an invalid and we ask people to retest. I think our invalid rate at this point is down around 1% or less. So we do pretty well. And because of that, and because of the investment in the robots, it allows us to really get through fast. So the bottleneck is getting the things, it's maybe 25, 30 minutes for the heat bath, I think, then processing them through the robots and then into the PCR. So we're able to do multiple runs per machine per day. And then someone asked if we're testing for variants. I kid you not, I'm missing a meeting right now to talk about that. We had not been doing that before, but there seems to be no reason not to. So given that where the labs are located, we'll probably start pulling some positives and think about checking for some of the variants right now. But that meeting and that discussion is happening as we speak.
Thank you so much, Dr. Carroll, for jumping in on this particular frameworks. It was very informative. Thank you. We'll look forward to hearing from you on the panel as well. So our next guest is Marianne Carroll, Vice President and General Counsel for University of Notre Dame. Welcome, Marianne. We're looking forward to hearing from you.
Thanks very much. Yeah, I was appointed early on, and I think this was back in March, to help head up our health policy subcommittee. Like IU, just as described, we also immediately back in March set up a reopening committee. I mean, we were very focused on when we can reopen as soon as we had to shut down. And we don't have a medical school, so we were looking for external assistance and really relied quite heavily on a number of experts who helped us, who were very generous for their help, including most particularly a team from the Cleveland Clinic that was very helpful to us in advising us. I just wanted to quick show you what we did when we started out. I mean, this is how we started the year. We had bought 75,000 masks. We had 10,000 gallons of hand sanitizer. I say 6,000 quarantine isolation room terms. That was over the course of the semester because we rented a number of hotel rooms to use for quarantine and isolation, but because there was quite a good supply in South Bend when we closed down, there wasn't much else going on. So we had pretty great access to quarantine and isolation rooms, but our people had to service them. And that meant in terms of cleaning and sanitizing, as well as getting food to the students who were occupying those rooms. We set up a hotline, and over the course of the semester, we fielded over 5,000 COVID hotline calls. And why don't we go to the next slide? We can talk a little bit more about our approach. We set up what we call CREW, the Coronavirus Response Unit. And at the beginning of the semester, we thought that we were in great shape. We had 50 people, and they were cross-trained. They could do all kinds of things. That was from nurses who were administering tests. We had a supply of tests, PCR tests from LabCorp, antigen from Quidel. At the beginning of the semester, we did not yet have surveillance testing, and I'll come back to that. This is in red. This was a huge lesson learned. This was way too small. as in terms of a team, a unit that was designed to flex and to respond to so many needs that crop up over the course of the semester. A real learning for us was how fast this thing moves. And by this thing, I mean not only the contagion, but also just the developments. And we have to just be so nimble to respond and react very, very quickly and to anticipate where it's going to go. As an example, that unit crew is now at about 400 people, mostly people who have been redeployed from throughout the university. We've had to bring in some temporary help, but mostly we've redeployed people who aren't that busy and could do things. And as I say, some of that was nurses to administer tests, but we need staff to drive students to the quarantine and isolation. We have ambassadors in buildings to remind people to put on their masks, et cetera. I mean, it's just and then I'll come down to some of the other activities as we get there. We had set up an on-campus testing site, and our approach at the beginning was that we were going to be doing symptomatic testing and care for students who tested positive for the virus. We always planned to set up surveillance testing. We are using the University of Illinois Saliva Testing regimen that Erin just described. We were slow on that. We started very early. Our classes started back August 10th, I think. And our plan was to have that surveillance testing site up and running by early September, which we did, but we were already then behind and playing catch up. And as was reported in the news, we actually went remote for a couple of weeks. We kept everybody on campus, but we had to go remote as we just kind of caught up and got a handle on what we were dealing with there. We have an on-campus contact tracing team like IU, though we're much smaller. We have about, I think Erin mentioned that they have maybe 40, and I think we have 25 to 30. So that is a big team. A mistake early on was that team was responsible not only for trying to contact trace students who had tested positive, but also doing what we're calling care and concern, the follow-up, the checking in with students who are in quarantine and isolation. And it was just overwhelming and they were falling behind. So we had to set up a separate care and concern team. But we've maintained that contact tracing team very closely aligned with our public health, local public health in St. Joseph County, who have been terrific partners with us. So there's great coordination between us. We set up quarantine and isolation protocols. One of the things very early on, at that time, and until very recently, the CDC was recommending that a student or anybody who was in quarantine had to be in quarantine for 14 days if you were in close contact with somebody who had tested positive. But very quickly on, we saw that there were few, if any, who were developing the virus after the first week. And so again, in coordination with our public health, we devised a 7-day quarantine protocol. The students who are in quarantine get tested with a PCR, nasal PCR on day 4, and with an rapid antigen test on day 7. And if they test negative on both of those tests and have no symptoms, they're released from quarantine after day 7. And at the conclusion of the semester, we've done a really in-depth analysis trying to identify anybody who was released from quarantine after just those 7 days and then develop the virus within the subsequent 7 days as a way to kind of control whether or not they maybe should have stayed in quarantine. And we only came up with 2 students altogether. And both of those we think had separate separate exposures that led to their development of the disease within the week after they were released from our 7-day quarantine protocol. And that 7-day quarantine protocol has now been adopted, I believe, by the CDC. This care and concern team is important to us. It's heavily staffed. It's a phone call every day to everybody who is in quarantine and isolation. I volunteer and do those calls on the weekends. We start off, we have a script. We start off by going through the any physical symptoms to see how these students are doing. We have had no serious illness In fact, as I'll mention in a minute, a huge proportion of our students have been even who have tested positive, have been asymptomatic, completely asymptomatic. But we also want to just check in to make sure that the students who were in quarantine and isolation were being properly cared for, and that they just got a call because, as you probably have read too, the mental health aspects of being kind of in quarantine or isolation can be pretty significant. The kids I worried about the most were the ones who tested positive on day 7. So they'd already been in quarantine for 7 days, and then they had to go into isolation for another 10 because, and that was their day 1. So those were the kids that just felt terrible for. Next slide, please. So here's a few more numbers. By the time we did get our saliva PCR testing, surveillance testing up, we were able to do about 76,000 surveillance tests. We also did pre-matriculation tests. We sent every one of our students, undergrad, professional, graduate, who were coming to campus, we sent them LabCorp PCR kits, excluding only those who, and they were mostly graduate students who lived in the local area. We ended up doing 12,500 diagnostic tests. So our current test capacity is about 2,500 a day, and that's just their surveillance testing. And so those 100,000 tests that were administered in the first semester, we anticipate doubling those in the spring semester. We will be requiring, our plan right now is that we'll be requiring every student to be tested, every undergraduate student anyway, to be tested once a week. And we may even go more than that as we get through the semester and kind of get the lay of the land. We will not send out the kits before the start of the spring semester as we did in the fall semester. Instead, we'll require every student who reports to campus, who matriculates for the spring semester, to report immediately for their saliva test. Their IDs won't be turned on, so those living on campus won't be able to access their residence halls or the dining halls until they've reported for their surveillance testing. Our surveillance testing lab, our on-site lab, is just as was described at IU, is doing a tremendous job. We're getting results back almost always within 12 hours, certainly within 24. So we will just require students to, after they check in that first night, to remain in their dorm rooms. We've staggered and scheduled their return so that we don't have roommates coming into the room at the same time, in another effort to try to control any spread of students coming in. I just saw a question asking me to mention too that not only did we do all of these, but we did some of those surveillance tests included required exit testing. We just felt that, well, we had a big football game on campus about 2 weeks before the end of the semester, and every student had to be tested. We had students were allowed to be in the stadium and they were separated. They had to wear masks, and they all had to test negative before they could get into the stadium. But we did feel it was only responsible then to test them again before we sent them back out to their home communities. So every one of the students was also required to be tested before they left, or they were not able to register for classes in the spring semester. Next slide, please. So the result is a full semester of in-residence students with nearly 90% of our classes taught in person. We, like IU, have had no incidents of classroom or lab transmission. We did not discover anything during the course of the semester, and we have spent the break here really going through the numbers with a fine-tooth comb, and we just have found none. I would say parties, especially the off-campus parties, was the root of a lot of the spread. And you'll see there that we had 1,800 cases, 1,400 of our undergraduates. As I said, we're fortunate that there were no serious cases. And in fact, a shocking number, once we really got the surveillance testing underway, very high percentages found to be completely asymptomatic. They were shocked that they were testing positive on surveillance testing. But we don't want that for the spring semester. I would say in terms of our lessons learned, I mentioned also you have to be really flexible and react quickly. And so we are trying to adapt and adopt that posture. The second thing is you cannot over communicate. And that goes not only for our students, but for faculty and staff as well. We just have to keep people, make them understand. After the beginning, I would say that we had terrific compliance with mask wearing. Very good, and maybe spotty at the very beginning, the first couple of weeks, but that turned around and it was very good. We need people to show up for surveillance testing when called. I would say that mask wearing and surveillance testing, and maybe I'd flip them, are the two keys we think to having a really successful spring semester. So our focus on ramping up our surveillance testing is another lesson learned, and we've already got all the everything in place to be doing that. We are also looking at vaccine deployment, although that would be a happy problem to have. And so far, we have no information that we will be getting vaccines to distribute, but we remain in close touch with our public health officials and stand ready to help as we can. So I don't know that I have any questions, but I'm happy to answer them now or just turn it back over for the next presenter.
Thank you, Marianne. I don't see any hands raised at this point, so we'll introduce our next guest. David Broker is the Chief Innovation and Collaboration Officer at Purdue Research Foundation. Welcome, David.
Thanks, JoBeth, and Happy New Year to everybody. Patty, thanks for inviting us. And I'd just like to start with my compliments to you and Erin and the team, and Carmel Egan, who preceded Erin, as well as Marianne and the whole team at Notre Dame. I think what you'll see is the common theme here is, and Erin alluded to it, we've become sort of a brotherhood, sisterhood of veterans in terms of starting something. And it really was a situation where we were trying to build the airplane while flying it at the same time. And so let me set the stage for showing kind of what our results were for the fall, and then I'll get into some of the things that we had to do along the way to get there. This comes straight from our dashboard, and again, I just did a screenshot of this. You can go on, you can see down there at the very bottom the link to our dashboard. Marianne alluded to communication. This became one of our primary communication tools, a way to let people know what was going on across campus. And you can see this is really the top half. There's a bottom half to this as well. So I would encourage people to, if you really want to understand what Purdue did, take a look at that. The other thing I'd point out is President Daniels released his annual letter yesterday, and it does also a very good job of describing in much more detail some of the key points along the way in terms of making our decisions and what we did. I'm just trying to capture a snapshot here for purposes of discussion and facilitating questions. But if you look, we had a population of about 50,000 people. That includes both undergrads, graduates, as well as faculty and staff. About a third of those, about 15,000, lived, what we would be in either residential dorms, or that also includes the fraternity and sorority and congregate living communities. Everybody else was off campus. So when you think about our community, it really is a community. Patty alluded to the fact that the hometown she grew up in had 10,000 population. The Greater Lafayette has about 2,000. So you can kind of understand the community is very important, and the engagement back and forth. And you'll see that here in a second. I'm going to take you through sort of the line that you see on our dashboard and sort of explain some of the things and why the line is the way the line is. But you can see we did over 90,000 tests. About a third of those were diagnostic, or these were related to students and other members of the Purdue community that had symptoms, called our health center. reported those symptoms, and it was determined that these people needed to be tested. So that's what we called our diagnostic testing. And if there were some direct people associated from a contact tracing standpoint that also needed to be tested as a result of someone testing positive, for example, their roommate or their lab partner or whatever, those would be in those numbers. The 2/3 of the tests, however, were surveillance testing. We had a random, sampling program where we tested about 10% of our population on a weekly basis. And that was sufficient, I think, at the beginning of the semester. But as the infection rose, we needed to increase and actually do more what I'll call hotspot testing. And I'll talk about that here in a second. But we were able to flex some of that surveillance testing. Our base was about 10%, but then we clearly were able to enhance or supplement that along the way. Marianne alluded to it. With our student population, given the way the pathology associated with the COVID virus, the overwhelming majority, over 98%, and this is actually the bottom half of our dashboard if you take a look at that, but over 98% of our cases were either asymptomatic or mildly symptomatic. And when I say mildly symptomatic, I mean they had maybe one or two of the classic symptoms: loss of taste or smell, headache, maybe a fever. And we had 7 hospitalizations along the way. So again, we would not have been, no school would have been able to open up had the pathology of this been different, and it wasn't, it didn't, wasn't a serious threat to the population of a typical college student. Along the way, obviously, Erin alluded to it, the need to be able to rapidly identify people, both symptomatically, asymptomatically, and then put them into either isolation or quarantine. We started off with, a couple hundred beds. And then when we started to look at what the potential is, we didn't know what we needed. So fortunately on the Purdue campus, we had our old graduate student housing area, which was built just after World War II. These are in our Discovery Park District area on campus. They were actually supposed to be torn down last year, but we didn't. And fortunately for us, we were able to convert this to over 900 beds of capacity for isolation and quarantine. And that really has helped us. We never really had to go much above maybe 150 to 200 because many off-campus students decided to either isolate or quarantine in their apartments, or many students decided to go home to isolate or quarantine. But having that kind of capacity is absolutely critical. It was alluded to, and this starts to get into the line that you see below. But I think an early driver of infection, we all did pre-arrival testing. I know that you did some. Notre Dame obviously sent kits to their students before the semester started. We at first were not going to do that. We didn't think that that was necessary, but as everybody recalls, towards the end of June, we started to see, with the reopening of the economy and reopening of communities, spread in Texas and Arizona and Florida. And many of our students come from those areas. And so we made the decision literally the weekend before the 4th of July that we needed to do arrival testing. And so we did that. And so coming in to the campus at the start, we had like a 0.7% prevalence rate, and that was across over almost 39,000 tests. But what ended up happening is you start to bring people together into the community, and those places where people are living, most closely with one another. And it just so happens that that's in fraternities and sororities and some of these congregate living environments, that's where the infection started to take hold, if you will. And so when we go back and look at sort of base case, where did the majority of our cases come from? We can trace it back to some form of congregate living, whether that was people coming into the dorms at the start of the semester. That's sort of the first hump that you see in the late August, early September time period. Obviously, there's interaction with that in-house member group with then the fraternity and sorority members that actually live off campus. So that's, again, an interaction that caused a second hump in terms of many of the cases that we saw. And then there was a third phase to this, and that was the new pledges for fraternities and sororities. So we were able to manage our way through that through our surveillance testing, doing extra surveillance testing in these particular areas. And then we started to see increases in the dorms because some of the students that were pledging fraternities, obviously they weren't living there, they were coming back and impacting their roommates in the dorm. And again, we were able to aggressively test in that situation to eliminate and isolate the sources of those infections. So we were able to, for the most part, once we started this semester, go without stopping or pausing. But I would point out sort of the rise in the line that you start to see in the October, November, late October, early November time period. And what happened there was, again, now the weather's turning. People are going more indoors. And what we started to see at that point in time was community spread. And that's really what we saw is the impact then later in the semester, really the last 2 or 3 weeks. It was a situation where it was all those off-campus situations, either for employees or faculty that live in our community or the students that live off campus. And that's really where we started to see the infections pick up. And again, we didn't see any evidence of spread in classrooms or labs. We were able to sort of stay on top of it in those areas like the fraternities and sororities, congregate living, and dorm areas where we have more control in terms of ability to test and isolate and quarantine. But that's our concern right now coming into the spring semester is there's still the high level of community spread and trying to continue to do. We're going to do arrival testing again for all students before the start of the semester to try to start as low as possible. But as Erin said, you can't drive it down to zero, but you do have to be able to be adaptive and respond and concentrate your resources in the emerging hotspots to stay in front of it. A key lesson learned is if you get behind, it's hard to catch up. So staying in front of this is very, very important. Next slide, please. Jo Beth, so thank you. So, building the airplane, flying at the same time, these are some of the things that I'd point to in terms of what we did. First and foremost, as Marianne alluded to, this disease spreads because of, person-to-person contact. So it's really behaviors that were going to be critical. We recognized early on that we couldn't test our way to success or anything like that, but we really had to capture hearts and minds and get kids in particular focused on what are the right sets of behaviors that are going to be required in this quote unquote new normal. That's the trite phrase that everybody used, but it was really, really true. We all needed to get people focused on what the new normal sets of behaviors were. And with the profile that I mentioned, that for most kids, they weren't going to get sick. It really was about protecting others and protecting your community. So we launched what was called the Protect Purdue Pledge. And it really outlined those 3 things. What do you need to do to protect yourself? What do you need to do to protect others? What do you need to do to protect your community? And the other universities did similar things, but mask wearing, social distancing, reporting of symptoms, being cognizant of you might be asymptomatic and you might still have the virus and you can still be contagious, and the people you need to protect are the most vulnerable, either the folks that are in either the age groups or the comorbidity groups that are the most vulnerable here. So it was really trying to capture the hearts and minds. And I can tell you in April, May, a lot of people generally across the country said there's no way 18, 19, 20-year-olds are going to do that. And we felt, quite differently. We felt that, look, it's an educational, it's a teaching moment, it's a learning moment, and kids want to do the right thing. We also learned that most of these kids were, stuck at home for the last semester or their spring semester from the prior year. And when I talked to and interviewed these kids, I said, what was the worst thing that could happen? They said, don't send us home. Don't send us home. We will do what it takes to stay on campus. And so I knew, and I think we knew, that if we set the expectations and we coached to that, and we expected people to follow through on that we would be successful. And sure enough, credit is due to our kids and our students in terms of their ability to follow through on those pledge requirements. Erin alluded to it. You got to be fast. You got to be nimble. We built and integrated everything into a common health center. This was the Protect Purdue Health Center. We ended up hiring a medical director. We had over 25, 30 case managers. We had 35 or 40 contact tracing organizations. So we rapidly built up an organization of on the order of 75 people to deal with the health side of this. Marianne alluded to mental health being critical, also academic support. So we created academic support counselors as well. So, at the end of the day, I don't have an exact count, but it was truly a team effort that involved hundreds of people at the end of the day. And you got to be able to be responsive. You got to be able to test, trace, then make your decisions about isolation and quarantine within 24 hours or less. And that's really where we've got to push, I think, at Purdue to just continue to get faster. We felt it was very important to control our own testing. In our community, we don't have a medical school, but we were able to convert our veterinary medicine college infectious disease lab called the Animal Disease Diagnostic Lab, ADDL, to a COVID lab. 11 days and 25 minutes after we submitted the CLIA application, we were able to get approval for that. We then subsequently introduced saliva testing. Now, we have not adopted the Illinois methodology for saliva testing. We're still using the Rutgers EUA, but we too believe that saliva is a much user-friendly sampling methodology, particularly for students. So we've enhanced our and have collaborative partners like Vault. We're going to be doing some antigen testing here at the beginning of the semester. We're partnering with Biodesics on that. And so we want to control, a core element of our testing capacity, but we also need to, for contingency reasons and for the ups and downs, volume requirements and capacity requirements, we need to also have a network of testing partners. I mentioned tracking hotspots. As I said, we didn't go into this, and we still don't intend to test all every day or once a week at this stage. We're still very much based on a statistically based sort of sampling and what we've learned in the first semester of where these hotspots are, and really trying to proactively stay on top of them. We were able to implement a contact tracing system that involved our campus Wi-Fi network. And so it didn't give you, down to 6 foot, the magic 6 foot resolution, for social distancing, but it gave you resolution within, let's say, 20 to 30 feet. And so we were able to use that to see where there were people that might have been exposed to a positive individual. As I said, most of the contacts that turned out to be positive came from living in situations, either in dorms or fraternities or off-campus apartments. I've alluded to the isolation, 900 beds. And then, along the way, we too bought gallons and gallons of sanitizer. We produced, our own PPE in addition to purchasing our own PPE. So there was just a lot of effort, expense, people involved in putting all this together. And much of these things were, going to the next level in terms of capabilities for the spring semester. Next slide. So lessons learned, Marianne said it best, you got to be nimble. What we also realized, because when we opened up the veterinary lab, the ADDL lab, we saw that the virus just kept shifting through the community. We started this because we were trying to bring on needed lab capacity in March, April timeframe, because if you recall back then, hospitals, it was taking 10 or 12 days to get test results. So we partnered with Parkview Hospital in Fort Wayne to try to bring on capacity. Well, they got through that, and then it shifted to outpatient testing for hospitals that wanted to open up their outpatient surgery. Then it became businesses. Then it became preparing for school. So, every 2 weeks there was something happening that caused us to continue to upgrade and adapt our plan. And that's not, and in many respects, I think the spring semester, the good news is we've got the vaccination coming, which is a new tool in our toolkit. We've got additional tests coming online, which will be good. But that also presents complexity in terms of how you manage all this. The technology parts of it are not the hard part. It's all the logistics of communication, establishing expectations, moving people, communicating a test result. And then by the time you communicate that test result, getting that person then to act on that and go into isolation or quarantine. Running the test can be done in hours or minutes. It's really all of those other logistical things that add up to the time and response time. So you need to be able to act very, very quickly. I can't underestimate or overemphasize the importance of working with your local community, both civic leaders as well as local health partners. We fortunately have great partners, Dr. Adler at the county level, and then our hospital partners at IU Health Arnett and St. Elizabeth, part of the Franciscan system. We meet every day with them. We have a half-hour, 30-minute call every morning. So we have vision or view into what's happening in the hospital in terms of bed utilization and capacities and things like that, and challenges that they're facing. And similarly, they have insight into what we're doing, not just through our dashboard, but what we communicate and talk about. We're very active in those conversations right now because we continue to see community spread, and we're anticipating community spread to go up coming out of the holiday period here. So those partnerships are absolutely critical in being able to work together. You've got to create this behavioral culture. As I said, that's the starting point. And it's critical to success. And you've got to fight through fatigue, right? Everybody by the end of the semester was tired of this. The teams involved in implementing all these things, the students themselves, we were all getting worn out. But you got to be able to battle through that. And coming into and re-densifying our campus here in the spring, we hope that everybody took a nice 3-4 weeks off and sort of recharged their batteries. But we've got to start, with the same amount of energy and robustness as we did in the fall last year. And then Marianne also said it very well: communicate, communicate, communicate. This can at one level be extremely complex, extremely technical, extremely scientific. But our role as leaders and as implementation teams is to try to keep things as simple as possible. Communicate, be able to say, we don't know when we don't know. We're getting a lot of questions now about what's happening with vaccination. When can we get vaccinated? Who's going to be next in line to be able to get vaccinated? Reality is, we're trying to manage, the state, the country is trying to manage that supply right now. And we have to be, honest with people and say, right now, we don't know, but we know what the initial priority is, but you've got to have to, work with us, trust us. As soon as we know anything differently, believe me, it's in all of our best interest to vaccinate people as quickly as possible. That's the long-term solution here. But right now, we don't have as many answers to all the questions people have. But it's a two-way street. If you're not communicating and sharing and being open to what you know and don't know, then it can take away from the trust of what you're trying to do. So communicate, leadership, those are very, very important elements to this. So I will pause there and turn it back to Patty maybe, and we can get into the general discussion on things.
Yeah, thank you, David. We will now go into our panel discussion. If I could ask all of our speakers to turn their cameras and microphones on, and our CEO, Patty Martin, will lead a moderated discussion. Again, to the audience, please continue to drop your questions in the chat. You can also raise your hand. If you do want to raise your hand and interact live with the panelists, we ask that you turn your camera on so that we'll be able to communicate with you. So take it away, Patty.
Thank you so very much. First, I want to thank my staff. You hear Jo Beth's voice here. In the background, we've got Erica Embry also hosting, and we are so thankful for Zoom's technology to enable us to have these conversations so frequently, quite frankly. And again, thanks everyone for joining. I also wanted to just make an observation that we have 3 very differently skilled folks on this call. I know Dave Broker from a very long time ago, and while he purports to be a scientist, he's also a business person. Dr. Carroll, we have not met, but I've heard marvelous things about you and appreciate your actual medical background. And Marianne is an attorney. And so we've had, as a former diversity officer at Eli Lilly and Company, I can say that one of the benefits of having a diverse group together is that everybody's bringing a little bit different perspective. I have to reflect on one of our first conversations that we had, where all of us were adamant that there would be no asymptomatic testing. At that point in time, we didn't know how we were, and I can make the large stated we, but the state did not know how we were going to be able to test those who actually needed to have testing.
Right.
And who would have thunk that we would be here with literally hundreds of thousands of asymptomatic tests being done across the state. I have 2 questions that I'd like to pose, and then I'm hoping that our participants here will jump in as well. One is, I'm curious on how each organization approached those who dissented, or who were non-believers in the virus, or who didn't want to participate, whatever screen you want to put on it. I know many folks were hesitant, particularly from faculty, to come into classrooms, and were there any learnings from that? And then many of our participants today are general employers. And is there something on a smaller scale for employers, anywhere from our team, which is 10 people, to a couple of thousand folks, that you would say, hey, if there was one thing you were going to do, what would it be? So those are 2 things to tee up. And I'm going to ask Broker, and then Marianne, and then Dr. Carroll to respond if you have a response.
Again, you had to. What's interesting is when we are where we are today, and we have a knowledge of what we've lived through, right? But we also have to kind of go back to what things were like in July and August to really appreciate your question, Patty. And I can tell you, I'll raise my hand. I had a wedding, right, in July for my daughter, and I swear, I made the front page of the Journal Courier. Task team leader sets bad example, right? It was like, oh my God. So that's the context of exactly what you're saying, right? So people were very fearful. We didn't know as much as we know today. But again, we had to communicate. We probably didn't do as much communication as we could have even back then. But the way we dealt with, that's why that pledge also became very, very important, because we had to sort of create a culture and a mindset that these are what the new normal behaviors are going to be. And you don't have to be here, right? From a student standpoint, we still provided students the option to do all online learning, right? We had several thousand students that did that. But I can tell you, the students wanted to be on campus, but it was this sort of quid pro quo, right? It's like, look, if you want to be on campus, here are the things you need to do. And you also saw, I think, with even the week before classes even started, we had a situation. Literally, we came out and we said we cannot have gatherings of a certain size, and if you're caught, in a party situation or off-campus event situation where you're, exposing other people, there are going to be consequences to that, right? Well, literally 4 hours after we communicated that, what happens? 38 people are seen out front of a congregate living situation. It's like, oh my God. So you had to, do the tough love, set the example kind of situation. And but it was, it was following through on your actions, telling people what you expected, and then managing towards that. That was really the best way to overcome the resistance over time. And then I think when people saw that we were serious about that, they started to say, okay. And now everybody had to come into it based on their level of understanding and commitment to it. But that's the only way you can get people to sort of embrace it. Something this big and complex.
So
very
Patty, I would answer your first question. I'm not aware that we had people, and we certainly didn't have a big problem with people who were, naysayers about the virus. What we have are 18 to 22-year-olds who think they are invincible. And that is particularly true after they have had the virus. And that's a real concern of ours coming into the second semester, with so many having tested positive, that they think that they're immune, and they're not. We don't know what the prevalence is of reinfection, but we've been told that it's happening. So we're very concerned about how we're going to get that message across. I think also that this is kind of a societal comment, that actually we saw them trying to adhere to these guidelines and trying to observe, some of the changes that they had. But what they would do is they would say, I just have my little pod. And they would let their guards down in their little pod of 6 people. But they had like 4 pods of 6 people, and every other person in those pods had other pods. So, when the contact trace, when we would find this, and the kids, I think, were honest. I mean, they thought that they were trying to control it. In terms of the employees, I guess I meant to say something just as Aaron described at, or similar to, I think, that he described at IU. What we did for the first semester, and we're going to renew it for the second semester, is that we added 10 COVID days to everybody's bank, all the employees' bank. We don't want them coming in if they're sick or they should be in quarantine. And especially our non-exempt population would be really hurt and really affected if they then were going to have to take personal days or lose pay. So we added 10 days. I just saw a report on that. And the uptake on that was not as significant as we expected. But again, we're going to renew it. What we did is we said those days expired at the end of December, and we'll add them in. We also gave 8 days for child or elder care. And again, not as highly, the uptake wasn't as significant as we expected. And I wonder how much of that is because so many people were working remotely, but still we're going to renew that as well. And I think that bought us a whole lot of goodwill, even if it was not taken. I mean, certainly people did take advantage of it. And, I could probably pull up, I don't know. Yeah, I think I can pull up the percentages, but it was a great, I think, morale booster and a recognition that we know that people have to take care of others.
That's great. Thank you. Erin, anything you want to add?
Sure. I mean, first of all, I can't say enough how important communication is, echoing what David and Marianne said. That, it took a lot of working at the beginning to get everyone, including leadership, aligned that we need to use a lot of we language and not you language, that we are all in this together and that this is not your fault. And there's certainly enough written on that. And there's only so much you can do to actually police behavior. I mean, we can control, masking on campus, we can, control distancing in the classroom, but there's a world out there. And so we have to do as much positive reinforcement as we can. We do, however, require everyone to submit to testing when we ask and to do contact tracing. You cannot opt out. And so all 120,000 plus are in the pool for mitigation testing, asymptomatic testing, and for contact tracing and everything else. It is possible to apply for exemptions, and they're easily granted for the testing. If you are never on campus, far away, in lockdown, you can get up, but you have to still comply and fill out the form and do everything else. There is no, I'm opposed to this, I don't believe in it, I'm not going to take part in it. And we required all faculty, students, and staff to sign an attestation, over the summer, basically agree with all of this. And certainly if you're an employer or staff who's coming to work, there is no getting out of any of this. And you can't duck the contact tracing calls either, which probably is one of the reasons we get to, closing cases in an hour. So one, I'd say half of it is building that sense of community and that sense of we're all in this together and these are the things we need to do to be safe. And the other half is, yes, you are all part of this community and we are all in this together and you must do these things so that we can all be safe.
Yeah. So we have a question from Nora to each of you asking if the protocols and communication, do you think, did it help slow the spread of the disease, perhaps broader than just your campuses, but beyond? Do you have any reflections on that question? The science, go ahead.
We have no randomized controlled trials, so I cannot prove that what we did caused everything, but we certainly don't have really good evidence that we made things worse. I mean, you see a lot in the, the New York Times had an article like, oh, we blew it for everybody, or campuses did, not we or any of the schools here. But I mean, like, again, I can show you that chart and I can put it up against Indiana. As schools opened in, and I would put this up for K-12 schools, as schools opened up in August and everybody lost their mind and lots of stories were in the paper about, cases are found in Brown County and, the world is coming to an end. Indiana remained quite flat in September and into October. And it was when we went to stage 5 that everything sort of went like this. And as everything went like this, we stayed incredibly flat. Now, I can guarantee you that we artificially drove down Monroe County's positivity rates because we were probably doing exponentially more testing than the rest of Monroe County. And given that we were massively testing asymptomatic people at a positivity rate of 1%, we're destroying the statistics. We probably were in Marianne County as well, and even in some of the other counties. But we were finding every case possible, putting it into quarantine and isolation, and keeping our population and constituents of 120,000 people at a very low positivity rate, even as the rest of Indiana was on fire. I don't know how that could be bad. Did that make things noticeably better? I hope so, but it'd be hard to point to what we were doing and what we were achieving, and I'd say it's probably similar at all the campuses, and say that we were not, at least not making it worse. I think there's a decent argument to be made that we were probably making things safer.
Yeah, I agree. I mean, we can't point to anything, but yeah. But I just wanted to dive in to make one additional kind of nuanced point. We were very, very conscious of the fact that we are such a powerful economic driver in our community. And had we shut down, I mean, people losing their jobs, it would have had a devastating impact. So we certainly didn't open up because of that, but any decision about what we made going through was, we were very mindful of the fact that we would have a significant negative impact on people's lives for a very long time if we weren't able to continue to provide the livelihoods that we do for so many people in our community. I don't mean to pat us on the back on that, but I think it's important that we keep that in mind too.
I think definitely that those lines that I showed on our dashboard, the spike that was occurring towards the end, that was purely coming from predominantly coming from the community, right? Because all of a sudden we saw the case mix shift. It was actually more faculty and employees were becoming positive. We saw many more off-campus people starting to test positive, and we separated out. We have all the county statistics, we have our statistics. Erin made a good point. We can eliminate our testing vis-a-vis the county, and we can show you the graphs. I don't have time to pull it up on this, but we clearly show that the 7-day average of cases in the county was at a different slope, and it was faster slope than what was happening on campus. So we know that we were not, we were obviously contributing to that to a certain extent, but it was coming from other places, not just from the campus.
Okay. So we have another question asking how your interactions with your local communities you all have between Bloomington, South Bend, and West Lafayette. Any observations or learnings from there?
Our county folks have been fantastic. Again, I can't compliment them enough. There were two things I'd point to. One is, on campus, we wanted to obviously have events to try to create as much of a normal experience as you could on campus. And obviously there's certain thresholds in terms of the number of people per event. And on a college campus, it's pretty hard to sort of stay within a general community guideline. So Dr. Adler in particular has been fantastic as we send them, here's our plans for a certain event. What do you think? And there's a lot of push and pull in those discussions, but we always arrive at a good place in that situation. So they've been fantastic. The other thing is, the state, and I know that we actually followed, I think it was IU's lead on this. The state is technically responsible for contact tracing, but if you look at the resources at the state level for contact tracing, it is woefully inadequate. Tippecanoe County has 3 contact tracers. We have 45, right? So we had to develop a handshake with the county that, look, we'll do some contact tracing in our communities that we have the ability to respond very, very quickly to. And then we have to hand off, again, be adept at handing that off to the county and back and forth and vice versa. So those two things, the event planning just is indicative of the type of coordination that we had with our local county people.
I'd second that. And I'd also say that we have tons of counties we have to work with because all our regional campuses and everything else. But and also like recognizing the limit, we are not the government. So when, like, for instance, our fraternity houses are not owned by IU, they exist in the community, and so we had to work with Monroe County to quarantine those. We cannot do that. And so we go to public board health meetings. We go to, their community meetings. We're in touch with their local community public health officials, as well as at the state level. We have to work with the government in order to make this function as efficiently as possible and to make sure that everybody is doing the things that they should and can be doing.
I'll express my personal opinion. There are a couple of bars I wouldn't have mind seeing shut down. I mean, there are a couple times I thought we close down those 2 bars and we'll be a lot better off. But
Bloomington, we have to give them props. They did the mayor of Bloomington, and they did a good job of, even when things were loosened, of constraining the number of people and what and could not. And so they worked incredibly well with us. But I would say, on the other hand, it's a give and take. They felt very strongly that we needed to test every person off campus as they arrived to campus, which was not perhaps our initial intent, but okay, so we did. So that was an extra tens of thousands of tests conducted in the end of August.
Our pre-matriculation testing was not our idea either. It was public health. They didn't want. So, yeah, it goes both
I have
ways.
to give a shout out to Mayor Dennis in West Lafayette. We had one example where we had our breakfast club, the first home game, and we just didn't like the look and feel of that. And so he actually led the charge, but we obviously supported him in terms of working with the local bar owners on basically forbidding breakfast club-like behavior. And our kids knew why, and they were better the second weekend. So
we have another question of turning towards this spring semester. I think you've shared quite a bit about things you're going to do and some what you would do differently. Vaccination sites. Lori's got a question here about the role that universities might play in being vaccination sites. Any conversations along those lines? Go ahead, Dr. Carroll.
We are absolutely. I mean, we're gearing up to. We're looking at proposals right now to actually do that because, again, we are part of a community, and we want to make sure that we are of service and doing just as we're part of this and everything else. So I know specifically at Bloomington, where in Indianapolis for IUPUI, there are healthcare systems you can't, they're everywhere. But in Bloomington especially, we're looking into making the infrastructure that we plan to build to vaccinate our constituents also potentially available to help with vaccinating Monroe County.
Okay.
that's actually an area, Patty, that I think there's, again, this notion of how we work together through the contact tracing between our universities and local health authorities. I think we have an opportunity to do the same thing on the vaccination side, because we have some infrastructure and just some capabilities that could lend to mass vaccination. I mean, that's really what we need, is the ability. I don't want supply to be the constraint, right? I would rather be waiting on a shipment than have a shipment there and not being able to inject it. So we need to figure out how to create that dynamic.
You need a different Herbie, if you've ever read that.
Exactly.
That book. Marianne, anything?
No, we certainly are willing and it's something that makes sense. We have a task force getting ready, but we've not heard anything. So we don't know when that will be.
So I'd like to just do a quick round robin, and then I'm going to close up with a pitch. Actually, I'm going to pitch before we close in case someone shows up, folks start to sign off. But we have a frameworks on January 27th at 8:30. It will be our third in this series. Jo Beth has just posted the link to register onto the chat. And many of you know me. I am a highly emotive person, but I also prefer to keep my opinions as opinions and facts as facts. And so what we're doing with this next frameworks is to educate any and all who would like to hear about emergency use authorizations, both for diagnostics and also for therapeutics, what they are, what they aren't, and the importance of those as a bridge to full authorization for these medications and diagnostics. And we're also going to have some conversation about the difference between the various vaccinations and how they're rooted. So mRNA technology is obviously new, and it's something I think we can all learn more about. So we're going to put some experts up in fact the end of February, sorry, January 27th at 8:30 to share some background on those. So we think an educated life sciences sector is really important. We hope that you'll join us there. So I'd like to do a quick round robin. I'm going to start with Dr. Carroll, go to Marianne, and then to David. Last closing thoughts.
This is a work in progress, I think, for everybody. But what I have been struck with is there's been, and again, clearly this is going to come from a biased standpoint. I've been struck by the fact that there's been a lot of coverage and discussion about how universities have potentially been dangers to their surrounding communities. But there's definitely a lesson to be learned about, that we have enacted in many ways the epidemiologic playbook that the public has often failed to. And granted, we have resources and capabilities that are not sometimes available, but there's things that could be learned. I mean, what we did to stand up 3 labs was not magic. The state could do it too. And when I say we can run 50,000 tests a week, it's not through special technology. It just requires resources and will. And as we continue to struggle with how do we do contact tracing, how do we do testing, how do we do everything we need to do to handle this pandemic at a public level, there's a lot that could be learned from what universities have done. And I hope as we shift in the next few weeks that there perhaps is a focus to how we can take the lessons learned that we've discussed here and apply them more broadly than just at an academic institution.
The first thing we're going to do is make sure that this video is available to our colleagues at the state. I just saw today that we posted 81 deaths in the state of Indiana, and anything that we can learn from this is going to save lives. Marianne?
Well, and I would just add to that, because that's exactly what I started to think. What is the learning out of this thing has been tremendous. It's been overwhelming on an individual basis, but there's so much good that can come out of this. And it's not only to help others through this or a similar type of pandemic situation, but there's just a lot of learning about what we need to do, what kind of flexibility we have, how we can be structured. I think all of us, including everybody on the who is participating, we've learned a lot about what the workplace might look like. So I think that is, if we can just catch our breath and step back to see what we've learned, it'll be so helpful, I think.
And I think to build on that, the spring semester is going to be different than the fall semester. We have new tools. The vaccine is going to be key. And so we've got, as we've all said, we've got to adapt to what those realities are and where we are in the virus. And that's going to require us all to change our plans, but there's going to be lessons that can be learned. And the faster we can apply those amongst ourselves and then share those with others, I just think it's going to benefit all of us collectively. And the state, we have a great community of people that are willing to help and support and jump in whenever necessary. So if we can be helping from a Purdue standpoint, I know Erin would say the same thing from IU and Marianne from Notre Dame. I mean, we can only do what we can do, but we can certainly tell you where we made mistakes, and we can certainly tell you what worked. So.
Well, I think that's one of the things that I'm going to charge our team with, is going through the transcript of this and highlighting the lessons learned. both to the positive and things that would be done differently. And we'll upload that to our site and make it available. It's been a long journey, but a very, and it's been one of the silver linings in this whole experience, is to have the opportunity to work with each of the universities and each of you. And that's what we like to do at BioCrossroads, is make those connections. And in this particular case, if we can save lives, that's what it's all about. So we wish you all well for your spring semesters. For those who've participated, thank you. And we actually are going to continue having our bi-weekly conversations with the university. So we'll continue to share everything that we learn. In the meantime, please stay safe, stay healthy, and Happy New Year.
Happy New Year,
everybody.
everybody.
Thank you, Patty. Thank you,
Bye.
Joe Beth, everybody.